Hi, my name is Jennifer Bellamy, and I'll be doing my presentation on the thorax and the lungs. Here is my consent form for my patient, stating that it's okay to film her and to upload it on YouTube for my teacher to see. First, I'll be starting out with inspection of the posterior chest wall. Make sure her thoracic cage is nice and symmetric. Make sure it's elliptical shape. Make sure the ribs are facing downward. Nice good slope downward. Make sure also the AP, anterior posterior diameter of the chest, is 1 to 2 or 5 to 7. Make sure it is not, she's not barrel chested. So that is correct. And what I'll do also is inspect the skin of the thorax, making sure there's no bumps, bruises, lesions, scrapes, or asymmetry. All right, and do you have any scars on your abdomen?
No.
Okay, so it is nice and pink, not too moist, no paleness. It is consistent with her background. She's Caucasian. I don't see any lesions or anything that would make anything worrisome about the thoracic cage. Also, the position of her breathing is nice and comfortable. She doesn't have any distress. She's got her arms rested in her lap. Her level of consciousness is alert and oriented, because when I asked her a question, she responded correctly. Facial expression is nice and relaxed. No distress. And also her neck muscles are not distended. They're nice and even for her size and shape. Now I'm going to palpate the to confirm symmetric expansion. So this is for palpation. I am going to put my hands on her posterolateral chest. So if you would turn for me. Okay, and put your hands down. There you go. So I'm going to put my hands on her posterolateral chest, and I'm put my thumbs at T9 to T10, and I'm going to slide my thumbs down and pinch, and I'm going to ask her to take a deep breath, and then take a deep breath in, and then I will see if my thumbs will separate symmetrically. Okay, so T9 and T10, and then I'm going to, okay? All right, let go. All right. All right, and they did separate symmetrically, and that's exactly what I'm looking for. Also, with palpation, I will do tactile fremitus. I will start at the top, and I will work my way down, and I will get her to say 99 in between each of these points to listen for sound that's generated from the larynx to the chest wall, and it should be symmetric. Okay, I'll start here.
99.
I'm using the ulnar part of my hand, or you could use the ball of your hand, but I'll be using the ulnar part. Okay.
99. 99. 99. 99. 99. 99. 99.
Well, hold on. There you go.
99. 99. 99.
Okay. All right, and it was symmetric, and I did feel that vibration from the larynx to the chest wall. So next, I will feel her spinous processes. I'll use the top of my 3 fingers, and I'll also palpate the chest while I'm doing that to find if there is any tenderness or any. Okay, can you lean down for me? Just your head. There you go. Pads of my 3 fingers. Spinous process feels nice and straight. Tell me if you feel any pain.
No pain so far.
Okay. Okay, so no pain?
No pain.
All right, great. All right, now for percussion. I will start at the apices, and I'll go across the shoulders, and then I will avoid the scapula and the ribs, because that will dampen the sound, and then I'll go in 5 cm intervals. So that is my percussion first, and then I'll do diaphragmatic excursion next. Okay? Just breathe normally. Nice tympanic sound is what I want to hear. Avoiding the scapula. Okay, so, and I actually heard where it did get dull, and that is the next diaphragmatic excursion. I'm going to percuss the scapular line, and I'm going to mark where it's dull. So I have some tape here. Okay, about right there. Okay, and then next I will go up from the abdomen and mark when it's dull, and I'm going to ask her to take a deep breath in and hold it. Okay. All right, take a deep breath in. Take a deep breath in. Are you holding it?
Mm-hmm.
Okay. Okay, about right there. Let it go. All right. Now, I will measure diaphragmatic excursion. And it should be about 3 to 5 centimeters. It can be 7 to 8. That is also normal. And hers is 4.5. So that's perfect for diaphragmatic excursion. Very normal. And that is the area that separates the lungs and the abdomen. So that's normal. Auscultation. Okay, you can turn around now. All right, and my stethoscope. With auscultation, I will do the posterior chest. I'm just going to ask her to lean forward, her arms slightly, just lean forward slightly, her arms on her lap, and I'm going to have her breathe through her mouth a little bit deeper than normal, and I'm going to start at the apices, C7, and I'm going to work down to the 7th or 8th rib, and I'm going to go in sequence. I'm looking for any abnormal or any kind of breath sounds that are not normal, or any advantageous breath sounds. So I'm going to actually ask you to turn around again. Okay. Okay. And I'm going to do this with the diaphragm. All right. Okay, and the posterior chest sounds nice and clear. No crackles, no wheezing, anything. And I did hear broncho-vesicular breath sounds where I'm supposed to, and that's in the main lung fields. And then vesicular at the top. So that is exactly what I'm supposed to hear. And those were low-pitched soft in the vesicular, and then the bronchovesicular are the moderate pitched, moderate amplitude with inspiration and expiration. So that was nice and normal throughout all lung fields.